All right, guys, can we start the session? Am I audible? शुरू करें. Hello, good afternoon, everyone. All right, guys, can we start the session? Am I audible? शुरू करें. Good afternoon, everyone. Okay, so we will discuss all the important topics which came in exam in a question-wise manner, right? So I'm trying to focus on last 5 years PYQs or PYTs which came in exam. Let's start with the question number one. Just look at the screen, try to understand this thing. A patient suspected of having a myocardial infarction was brought to the emergency department and succumbed after 3 hours. Means patient died after 3 hours. During autopsy, heart was stained with TTC. So this question I am seeing it is coming in exam from past 3 attempts. So they are asking you basically about triphenyl tetrazolium chloride test, TTC test. When is the best time to use TTC staining for optimal visualization of myocardial necrosis? Okay, first try to give your inputs. Try to give your inputs. What is the answer? So first, try to understand this thing. We have this test called TTC test. TTC test means triphenyl tetrazolium chloride test. So topic that I'm discussing now is TTC test. So whenever you want to see the ischemic area and we want to differentiate this from viable tissue, what we see, if you see this viable tissue and ischemic area, later on I'll show you the image of this also. Just try to understand this thing. So when you see this viable tissue, this will appear brick red in color. Brick red in color, and ischemic area it will appear pale yellow. So this is the thing which you have to remember about TTC test. TTC test or triphenyl tetrazolium chloride test. And understand this thing. Suppose what is the best time? Best time you will see this where within 2 to 3 hours. Answer will be B. So best time you will see optimal visualization you will see in 2 to 3 hours. So this is about your triphenyl tetrazolium chloride test. Done. TTC test. Okay, moving to the next one. Try to answer this. Alpha fetoprotein is a tumor marker used in diagnosis and monitoring of various conditions. But now what they're asking you, it's the tumor marker for which tumor? This germinoma, hepatoma, choriocarcinoma, epithelial cell tumor. So alpha fetoprotein. Now see, for choriocarcinoma, we have a marker called beta HCG. So here remember alpha fetoprotein, this also question came many time in exam. It's a marker for two important tumor. First is your hepatoma, or I can say it's a marker of any liver cancer like HCC. Second, it's a marker for yolk sac tumor. Both these question came in exam. Yolk sac tumor. So alpha fetoprotein, it's a marker of hepatoma, HCC, yolk sac tumor. Means liver cancer and yolk sac tumor. Am I clear? So topic which is next important topic. So just I am telling you the not only the question but also important topics. So first important topic is you have to focus on TTC test. Clear? Second important topic which we have to discuss is tumor marker. So now understand this thing. They ask you question on various tumor markers. So I'll tell you some important, only few, only the important one. So first we already discussed, that is alpha fetoprotein. Alpha fetoprotein means hepatoma and yolk sac tumor. Yolk sac tumor. Second important tumor marker we have to remember is beta HCG. Beta HCG, understand, is the tumor marker for choriocarcinoma. And GTN, gestational trophoblastic neoplasm, like molar pregnancy, partial mole, hydatiform mole. So these are molar pregnancy. That's not hydatiform mole, means partial or complete mole. We call them gestational trophoblastic neoplasm. Then what they ask you? They ask you CEA, very, very important. Carcinoembryonic antigen. It is the best marker for colon cancer. Best marker for colon cancer. They're asking you a question, calretinin. Calretinin is the tumor marker for mesothelioma. Mesothelioma. Chromogranin. Even this question came in last attempt. Chromogranin. It's a marker for carcinoid tumor. And now the very, very important what we have CA. CA means we have CA 15, CA 19.9 and CA 125. CA 15, CA 99, CA 125. So to make you understand this CA, what I am telling you, just try to understand this thing. Suppose this is a female. And when you see a female body, look at the screen. When you see a female body, first will come breast, then colon, pancreas, then ovary. Similarly, in number wise, numbering, what you can see 15, 99, 125. 15 for breast cancer, 19 colon, 125 ovary. Simple. So CA 15 is for breast cancer. CA 99 is for colon and pancreas cancer. And CA 125 it is for ovary cancer. So these are some of the important tumor markers which you have to remember. Very, very important. That okay, moving to next important question, come important topic. So what is that topic? Let's see. A 55-year-old female. So first hint in the question is remember always age. So focus on the age 55. Then hint is sex, female. Complaint of persistent headache. So this female is having persistent headache. Now headache can be seen in many, many conditions. A CT scan of head reveals a brain tumor. In CT you can see brain tumor. Although most of the brain tumors they are not detected on CT, for that we have to do MRI scan. But here they are telling you it is seen in CT, it means it's a big tumor. Histopathology is having some oma body. So that is all your hint here. So based on this, what is the diagnosis? Easy one. Dr. Supra, we are expecting almost, I can say 10 questions from this session. This is my expectation, right? So try to answer. So these are just 25 MCQs which I am discussing initially. Then I'll tell you about the crisp part. So सब कुछ पढ़ेंगे हम, don't worry. So what is the diagnosis? So look at the screen. All the blastoma, without any doubt, all blastoma universally will occur in children. So these two are ruled out immediately. So by just seeing the age, you have ruled out, because all the blastoma they occur in children. Now coming to headache, female symptoms are more during pregnancy because of progesterone level. So this is the patient of meningioma. It's the patient of meningioma. So now what you have to remember the details of all the brain tumors. So next important topic will be brain tumor. Done. So what are the different types of brain tumor which you have to remember, and what are the questions which they ask in exam? So first is meningioma, because nowadays they are not asking you of most common, least common. So meningioma, so we'll talk something about meningioma. Next brain tumor is oligodendroglioma. Oligodendroglioma. Okay, then it's actually a peripheral nervous system tumor. We call it schwannoma. Schwannoma. Then what we have medulloblastoma. Medulloblastoma. Ependymoma. Any other brain tumor you remember? Next we have PCA, pilocytic astrocytoma. And then we have GBM, glioblastoma multiforme. This PCA, GBM, these both are type of astrocytoma. Right? So these are the brain tumors. So starting with meningioma, just remember meningioma is something which is more in females. It is something that is more in females. And when you see a patient of meningioma, understand what they ask you in exam. They ask you this tumor is progesterone dependent. Progesterone dependent means patient will have more symptom whenever patient is having. Okay, one more. Ritesh, very good. Craniopharyngium. We'll also discuss craniopharyngium. Craniopharyngium. Pituitary adenoma I am not discussing here, otherwise it will take a lot of time. Okay. In meningioma, what they ask you now, see, pathology question they will ask you only biopsy finding. So what is in biopsy? We'll find some of our bodies. You will find some of our bodies. But what are other hint? Understand this thing. This tumor is compressing. It is like irritating to your brain, pain sensitive structure. So your meninges are pain sensitive. So remember the most common symptom patient will develop is headache. And after headache, remember patient can develop seizures. So there will be headache followed by seizures. Done. So just remember female trauma bodies and symptom will be more in pregnancy. Oligodendroglioma, understand? For this, what they ask you, it occurred due to a gene mutation. That gene is IDH1 gene mutation. And this oligodendroglioma, we also call this non-veg tumor. Why non-veg tumor? Because here you will find fried egg appearance. Fried egg appearance. Then you can notice one more finding that's called chicken wire pattern. Chicken wire pattern. Okay, now coming to schwannoma. Schwannoma, understand this thing. Okay, now one more question they ask you, like schwannoma and meningioma, these are two tumors which are associated with a genetic diseases. Anyone, can you tell me which one? That genetic disease will be neurofibromatosis type 2, NF2. So they ask you question like this. Look at, listen to me. Most common cytogenetic abnormality seen in a patient of meningioma or schwannoma, it is neurofibromatosis type 2. Simple. I repeat, most common cytogenetic abnormality, it is NF2. Schwannoma, understand, it's a tumor where you can see like this tumor is having Verroque bodies in biopsy. So what they ask you Verroque bodies. And this Verroque bodies will have two patterns. One is called Antony A pattern and we have Antony B pattern. Antony A, Antony B pattern. Okay, now coming to medulloblastoma and ependymoma. So from this, what they ask you these two. They spread via drop of CSF. So they both spread via CSF drop. And what we call this drop metastasis. Drop metastasis means they spread via CSF. For medulloblastoma, one more thing they ask you in exam. We will have a peculiar rosette formation. What is that rosette? Anyone? Can you tell me? What is the name of rosette in medulloblastoma? Come on. Shubham, try to answer. Ritesh, what is the rosette? What we see? Which type of? Not flexner, intestine rosette, any other rosette? Homer right rosette. Very good. You will find Homer right rosette. Homer right rosette. So just make sure this is very important slide which I am making. Now coming to PCA, pilocytic astrocytoma. PCA and GBM, understand this thing. These are types of I can say astrocytoma. So PCA is called grade 1 and GBM is called grade 4. So grade 1, grade 4. Now difference between these two is, understand this thing. PCA is something that we see in children and it will have good prognosis. Good prognosis. And GBM something that we see in adult. So mostly you will see person will be above 45. And this is something which will have bad prognosis. But more important, what they ask you biopsy finding. So in PCA, what you will find? In PCA, you will find a red color fiber. These are called rosenthal fibers. Rosenthal fibers. And in GBM, you will find pseudo palisading body. Pseudo palisading bodies. And sometimes you can find glomerular bodies. Glomerular bodies. Now some PCA, it's like a cystic nodule. It is nothing, it's a cystic nodule. And GBM, what they ask you, GBM, understand this thing. It's a tumor which spread from one hemisphere to another hemisphere. So we call this trans hemisphere spread. And because of trans hemisphere spread, we call this butterfly tumor. We call this butterfly tumor. So this is about your GBA. Okay, now coming to craniopharyngioma, it's a tumor which will have a lot of calcification. So C4 craniopharyngioma, C4 calcification. So tumor will have a lot of calcification. And when you see this tumor, understand this thing. This C4 children, it is something that is seen in children. And just remember, like this is a tumor which is having even poor prognosis even after surgery. It's having a poor prognosis. And I can say the symptom will resemble like pituitary adenoma. So this is about a slide where you will see one MCQ exam. Very, very important. So let me highlight the pathological hint. Samoma bodies are seen in first hint. Second hint, they ask you chicken wire appearance, fried egg appearance. Verrucate bodies are seen in schwannoma. Homer right rosette, medulloblastoma, rodental fibers, PCA, pseudopalisading bodies, glomeruloid bodies, GBM. So these are the MCQs which they ask you. Remember, mark my word, one MCQ exam from this slide. Very, very important about brain tumor. Is it clear? Ritesh, Shubham, done? Very, very important. So this is about the summary of all the biopsy finding of different brain tumors. So next important topic which you have to remember, that is brain tumor. Okay, moving to next MCQ. Let's see how many of you can answer. Following is seen in irreversible cell injury. So again, this type of question you will always see in exam. Like what are the changes in reversible? What are the changes in irreversible? So let's see. Try to answer. Try to answer. Okay, I'll come back to this question. So here I'm writing RCI versus IRCI, means reversible and irreversible. So let us compare these two. Let us compare these two, and I'll tell you first, before comparison, let me talk about the similarities. So similarities you can see, like most common cause for both, it will be hypoxia. So whenever there's hypoxia, that can lead to ischemia. And as a result, you will notice like first organelle to be affected in both the case. So first organelle to be affected will be mitochondria. So these are the similarities that you can see. So see, most common cause hypoxia, or you can say ischemia. First organ to be affected will be mitochondria. Now they ask you what are the changes. So understand this thing, in reversible cell injury, you will see there will be cell swelling. There is cell swelling. The cell swelling is also called as hydropic change. Hydropic change. So when cell is swelling, you can see organelles are inside the cell, so they will also swell up. So there will be organelle swelling. Organelle will swell. Now we can see like a rough endoplasmic RER, rough endoplasmic reticulum will have ribosomes, so that will lose their ribosomes. There's loss of ribosomes. Loss of ribosomes. From RER, you can see this loss of ribosomes. Then, so understand this thing. They ask you, what about the nuclear change that we see? So nuclear change, you will see this will be called clumping. Of chromatin. Now compare this with irreversible cell injury. You can see membrane damage. Membrane damage is a classical feature that we see in necrosis. However, membrane is intact in apoptosis. Then you can notice this loss of ribosome you will also see here. Same change you will see here. Instead of clumping, you will see three nuclear change. First is called pycnosis. Pycnosis means shrinking of nucleus. Then you can see karyorrhexis, like fragmentation of nucleus, and ultimately you will see karyolysis. So these are the series of change. Pycnosis means shrinking, then karyorrhexis, fragmentation, karyolysis means disappearance. Now try to understand this thing, how we differentiate in the mitochondria. In irreversible injury, you will find calcium-rich densities, and these calcium-rich densities are called amorphous density. So this is the most important thing. So you will find amorphous densities. So amorphous densities, they are classically seen. Am I clear? So now let's see the question. You will get the answer because they ask you all are seen in reversible except. All are seen in irreversible except. This type of question they always ask in exam. So let's see. Ribosomal separation you will see in both. This loss of ribosome you will see here also. You can see in both. Then you can see clumping of chromatin. So this loss of ribosome you will see in both. It's not the answer. Then they ask you clumping of chromatin. It is not the answer. Why? Because it is something that we see in reversible cell injury. Blab formation. Now see, whenever cells fluids are going inside the cell, then membrane will have blabbing. So blab formation, understand? This blab formation occur because of cell swelling. So blab formation occur because of cell swelling. So that's the feature of reversible cell injury. So answer for this question is large amorphous density. So many time repeat question, many time came in exam. So they ask you all are seen in reversible cell injury except very important. Done. So just remember most common cause will be hypoxia for both. So this is a topic called reversible and irreversible. Now compare this. A 45-year-old lady with a history of long-standing goiter. So first hint in the question, long-standing goiter. Patient को काफी साल से goiter है. Presented with solitary thyroid nodule. There is a thyroid nodule. Examination of thyroid mass shows nest of polygonal cells and pink eosinophilic extracellular material. So this is the hint in the question. Can you see the hint, anyone? So pink color, extracellular. This extracellular is the hint which I think it's the most important hint. In the question, if they could have given like patients having apple green color in polarized microscopy, then you could have nailed the answer in a better way. But now they are telling you pink eosinophilic, but hint is extracellular. What is extracellular? Extracellular material is amyloid. So just remember, whenever you see amyloid is always extracellular deposit, right? So it is amyloid. So amyloid is extracellular deposit. Now understand this thing. When you see amyloid, in amyloid, you can see in thyroid cancer, you will see which type of amyloid. You will see acal amyloid. You will see acal means cal stand for calcitonin. And this acal amyloid, understand this thing, it is seen where? It is seen in which cancer? It is seen in MTC. MTC means medullary thyroid carcinoma. Medullary thyroid carcinoma. Done? So answer is, so just remember, medullary thyroid carcinoma. So here we will talk about all the different thyroid cancers. So if you ask me what is most common benign tumor of thyroid, most common benign tumor will be thyroid adenoma. But nobody is interested in asking about benign tumor. So what they ask you question on malignant thyroid tumor. Right? So malignant thyroid tumor, what we have papillary carcinoma of thyroid. Papillary carcinoma of thyroid. We have follicular carcinoma of thyroid. Then you can see we have medullary carcinoma of thyroid. We have lymphoma of thyroid. And we have anaplastic carcinoma of thyroid. So these are the cancer, papillary, follicular, right? Okay, thank you so much. Happy to see you again. Papillary, follicular, medullary, lymphoma, anaplastic. So these are 5 thyroid cancer. So now understand this thing. How we can remember? We can remember a mnemonic. That mnemonic is please feel my lean abs. Please feel my lean abs. Right? So understand this thing. Please means it is papillary. So this is a sequence from most common to least common. And it is also a sequence from least dangerous to most dangerous. From least dangerous to most dangerous. Get my point? So now try to understand this thing. Most common thyroid cancer, papillary. Least common, anaplastic. Which type will have best prognosis? Papillary. Worst prognosis, anaplastic. Which is considered curable type, papillary. Which is considered having worst outcome, anaplastic. Am I clear? So now try to understand this thing. Okay, we'll also do the medicine division, don't worry. So papillary, follicular, medullary, lymphoma, anaplastic. Now try to understand this thing. In thyroid, we will see 2 types of cells. Look at the screen, try to understand this thing. So these are the cells in the thyroid. We call them. These are the cells called follicular cells. So these are the cells called follicular cells. So these are the follicles. So these cells are called follicular cells. Now understand this thing. Surrounding the follicles. So these are the cells called follicular cells. So these are suppose follicular cells. These follicular cells, understand this thing, they will produce T3, T4. They will produce T3, T4. Right? This T3, T4, understand this thing, they will produce T3 and T4, they convert into each other into periphery. Surrounding the follicular cells, we have parafollicular cells. Parafollicular cells. These parafollicular cells are also called as C cells. Parafollicular cells are also called as C cells. And understand this thing, these parafollicular C cells, what they will produce? They will produce calcitonin. So parafollicular cells also called as C cells, and they will produce calcitonin. So now try to understand this thing, right? Parafollicular cells and follicular cells. So suppose if I ask you like which tumor originates from parafollicular cells, so only one tumor originates, that is called your medullary carcinoma of thyroid. In short, I am writing MTC. So MTC is medullary carcinoma of thyroid. All other cancer means which other cancers? Papillary. So all other cancer means papillary, follicular, and aplastic. So these cancer, they originate from follicular cells. Lymphoma is originating from lymph node. Simple. So understand this thing. They ask QMTC. Suppose this T3, T4, understand this thing, they will bind with thyroid binding globulins and albumins. TBG, TBA, thyroid binding albumins. So suppose when you see thyroglobulins, suppose understand this thing, suppose they can ask you a question on tumor marker. If thyroglobulins are increased, it could be which cancer? Papillary, follicular, and aplastic. And calcitonin will increase. That's a tumor marker for MTC. Simple. And this MTC, understand, they ask you two more things in MTC. First is, this MTC is associated with men syndrome. Which men? All men are not the same. Which men? Men 1, men 2A, men 2B. Men 2A and men 2B. So it's a part of men syndrome, multiple endocrine neoplasia. This MTC, understand this thing, it is associated with a gene. That gene is called RET gene. RET gene. Done. So these are the MCQs. Then few more questions they ask you on papillary carcinoma. What they ask you on papillary carcinoma, understand, they ask you papillary carcinoma of thyroid. It is most common type which we have already discussed. Here you will find orphan Annie appearance. Orphan Annie eye appearance. Then in papillary type, understand, you can also see cyst formation. And this is the one which is associated with radiation. After radiotherapy, you can see patient can develop which cancer? Papillary carcinoma. Is it clear? Done. Am I clear? Okay, just remember follicular carcinoma, they ask you one thing like it's the carcinoma. Carcinoma, but spread. It's spread via hematogenous route. It's spread via hematogenous route. Okay, so that's why we don't do FNAC in this condition. So this is about the summary of different type of thyroid cancer. Okay, moving to next topic. So let's see next one. A 9-month-old child is admitted to ICU with a history of recurrent sinusitis. So history of sinusitis, first hint in the question, and otitis media, followed by staph aureus infection. Lab results having low level of immunoglobulin gain and low quantity of plasma B cells. Normal reaction to environmental antigen on the skin. What is most likely diagnosis? Anyone? Okay. So try to understand this. Ataxia telangiectasia, it occurred due to ATM gene mutation. It occurred because of ATM gene mutation. So patient will develop ataxia and there will be dilatation of small blood vessels. We call this ataxia telangiectasia. Now understand this. CGD occurs because of deficiency of which enzyme? NADPH oxidase. It occurs because of NADPH oxidase deficiency. CGD. And DG also, understand this thing. We also call this thymic hypoplasia. We call this thymic hypoplasia. I am giving you time to answer till then. Try to answer. And Bruton A gamma globulin, understand, we also call this Bruton disease. So basically, it's the defect of opsonization. Defect of opsonization. So try to answer. First, tell me your diagnosis. Anyone? Okay, so let's understand this thing. So we have BTK. The topic is immunodeficiency. So we have B cells. B cells convert into plasma cells. So B cells, they will convert into plasma cells. They will convert into plasma cells. Then plasma cells will produce immunoglobulin. That immunoglobulin is IgM. So first immunoglobulin which produces IgM. This IgM, understand, it will convert into different antibodies depending on the need. Suppose if body does not need anything else, it remain IgM. It remain IgM, or it can convert into IgA, or it can convert into IgG, or I can say it can convert into IgD, or it can convert into Ig. So this phenomena, when one antibody is converting into different other types, what we call this class switching. It is called as class switching, or what we also call this isotype switching. Right? Now this B cell convert into plasma cells. It occurs because of BTK. What is BTK? It is called Bruton's tyrosine kinase. We call this Bruton's tyrosine kinase. BTK. The B cell converting into plasma cells. Now understand this thing. Bruton tyrosine kinase. So if this enzyme is absent, let's say this is absent. This is absent. This BTK is absent. So no plasma cells, no IgM, no class switching, so no other antibody, nothing. Simple. So getting my point or not? So when this enzyme is absent, you will notice all these antibodies will be absent. So that's why we call this A gamma globulinemia, means absence of all immunoglobulins. Is it clear? So this is your Bruton's. So just remember one more thing, Bruton disease is X-linked recessive. And because of this nature, it is something that is seen in boys. Is it clear? So they ask you question on Bruton's A gamma globulinemia. Am I clear? So this is about your Bruton's A gamma globulinemia. Okay, moving to next one. Try to understand this thing. This question also I have seen in exam. Even recently I got a patient with the same condition. Even recently I got a patient with the same condition. I'll tell you. Just try to answer. Try to answer. This question came in your exam. Even I got a similar patient like this. So that's why it's an important topic. They can ask nowadays, like previously, like we don't have enough diagnostic tools, but now we have a lot of diagnostic methods. So you can see these type of cases are rapidly we can detect because of different diagnostic measures. So try to answer this. Try to answer. Okay, so look at this. You can see the chromogram. If you see it carefully, what you can see, hemoglobin electrophoresis method, and you can notice here chromatogram is suggestive of HBD Punjab, hemoglobin D Punjab. So what it is? What is this pattern? HbA level, HbA2 level, HbF level, HbS, HbD, HbA1c. So these are what? These are different types of hemoglobin. HbA1c is your diabetic hemoglobin, right? So they are asking you like a question on HBD Punjab. So that is like a type which we see in those people living in Baga border or people like living in Sindh area. So most of them are either Sindhis, Punjabis, Muslim. So it is, I can say, a sickle cell anemia, mini version of sickle cell anemia or thalassemia. So let's see. Patient underwent cholecystectomy and black pigment gallstones were noticed. So whenever we have hemolysis, you can see in hyperbilirubinemia condition or hemolytic anemia, you will notice always pigmented gallstones. Gallstones are of two types. One is called pigmented, second is called your cholesterol that will be yellow in color. Pigmented means bilirubin gallstones. So they're asking you least likely. So just understand this thing. All hemoglobinopathies will have more chance of stone formation. Means more the hemolysis, more chance of stone formation. So understand this thing, more the hemolysis, more chance of stone formation. So sickle cell anemia will definitely have. Sickle cell anemia will have hemolysis, so there will be chance of stone formation. Now what is HbH disease? Anyone? Hemoglobin H disease. I told this, it is a type of alpha thalassemia. When 3 alpha genes are absent. So it is a type of alpha thalassemia. Right? Now understand this thing. Now we are left with two options: beta thalassemia minor and HBD Punjab. So these both understand this thing. These both are condition which will have less chance. Now see, in the question the answer could be beta thalassemia major. Then straight away we can rule out it. So they are asking you least chance, least likely cause. So understand this thing. Beta thalassemia minor is something which is more common. It is something which is more common. So prevalence wise, you can see many cases of beta thalassemia minor, and it is something which is less common. It is something that is less common. Get my point? So now see, sickle cell anemia will also have two things: sickle cell anemia, sickle cell trait. But again, both are common. So any major form of illness will have more chance of stone. So these first two are ruled out because they are severe. Now comparing to these two, if you see, beta thalassemia minor will have chance of stone, but remember it is that common. So some people can develop this, but HBD is very very rare. It's not that common. So by doing this, we can rule out the answer. It is HBD Punjab. So HBD Punjab is one of the rare type of hemoglobinopathies. Okay. So we have few more like Avata, hemoglobin Punjab. These are some rare type of hemoglobinopathies. What are other hemoglobinopathies? Understand this thing. So hemoglobinopathies means what we have? We have sickle cell anemia. Then we have thalassemia. Then what we have? We have, I can say, thalassemia, all the types of thalassemia means alpha and beta. Alpha and beta. So in alpha thalassemia, what we have? We have HbH disease. HbH disease, and one more what we have? We have Bart hemoglobin. So Bart, it is most severe form. Bart hemoglobin. In beta thalassemia, what we have? We have minor, intermediate, major. Minor, intermediate, major. And major is also called as Cooley's anemia. Major is also called as Cooley's anemia. Now, what else next we have? In hemoglobinopathies, we have HBD. HBD, or we call this HBD Punjab. Then we have Avata hemoglobin. So these are some rare types of hemoglobinopathies like Avata, HBD. These are rare. What is common? Common is thalassemia and sickle cell. Am I clear? Okay, moving to next. This is again a easy question which came in exam. Which of the following is decreased in acute inflammation? Very very important. Now what they ask you like these are basically acute phase reactant. Acute phase reactant means we call them APR. Acute phase reactant, also we call them APR. So understand this thing. Something which increase whenever we have some inflammation, something in body will increase. So what we call them? We call them positive APR. Positive APR means positive acute phase reactant. And something will decrease. Suppose something is increased. Suppose you are having inflammation, something in the body increase and something in the body decrease. When something in the body decrease, what we call? We call them negative acute phase reactant. These are called negative acute phase reactant. So when something increases, what is increase? What we check? We check ESR. So ESR means we are detecting fibrinogen. Then we have CRP, C-reactive protein. These are increased. What else is increased? We have different type of interleukins they can increase. Interleukin 1, interleukin 6. So these are increased. So something that increase. And what is decreased? So decrease will be albumin, globulin. Albumin, globulin. So these are something which decrease. Like you will see hepatitis patient, sometimes cirrhosis patient, you will see their albumin is low because they are in nephrotic syndrome. You will see albumin is low. In sepsis, you can see albumin is low. So for sepsis, we have a marker that's also increased. What is increased for sepsis? Procalcitonin. So anything that increase, we call them positive acute phase reactant. Anything that decrease, we call this negative. Simple. So let's see. So look at this. Whenever we have inflammation, C-reactive protein is increased, ferritin is increased, hepcidin is increased. So ferritin, hepcidin, these are also, this ferritin, hepcidin, what are these? This ferritin, or I can say hepcidin, these are also increased. So these are positive acute phase reactant. What is not increased, what is decreased, that is called albumin. And albumin is called as negative APR. So we call this negative acute phase reactant. Okay, this is negative APR. So very, very important. Okay, next question I am showing you, and I guess you will make mistake in this. So try to answer this. Try to answer next one. Try to answer next one. Ritesh Shefali, try to answer. Try to answer. A chronic alcoholic patient present with abdominal pain and vomiting. So you can see abdominal pain and vomiting. He had similar episode in the past along with steatorrhea, weight loss and fatigue. Past में भी ऐसा ही कुछ था. साथ में क्या दिख रहा है? Steatorrhea. Steatorrhea means fat is too. Following a type of necrosis in this patient. What do you think? What do you think? First tell me what is the diagnosis? What do you think? What is the diagnosis? So now see, it's a chronic alcoholic patient. Now he's having abdominal pain and vomiting. Similar episode he had. So it's the patient of chronic pancreatitis. It's the patient of chronic pancreatitis. Right? Steatorrhea, fatty stool is there, weight loss is there. Maybe this pancreatitis converting into pancreatic cancer also. So now what is the type of necrosis? So in pancreas, we see two type of necrosis. If it is acute pancreatitis, what I told you, in case of acute pancreatitis, you will notice, let's say pancreas is pancreas. So we have suppose acute pancreatitis. Or we have chronic pancreatitis. So pancreatitis, whenever person is having for the first time, so you can see in acute, you can notice this is pancreas. Surrounding the pancreas, you will see we have fatty layer. So in acute one, what you will notice? In acute, you will notice like this patient will have enzymatic degradation. So this lipase amylase, here you can see degradation. You can see necrosis here. And this type of necrosis is called as liquefactive necrosis. So that is why you will see this enzyme lipase amylase, they will come out of the pancreas, they will increase in the blood. But in case of chronic pancreatitis, you will see there will be necrosis in this layer. And this layer is called as peripancreatic adipose tissue layer. So you can see necrosis here. And this necrosis is called as fat necrosis. So chronic pancreatitis, fat necrosis, acute, you will find liquefactive necrosis. So it's a patient of chronic pancreatitis, so you will find which type of necrosis. Okay, let's see. Caseous necrosis we'll see where? In TB, systemic fungal infection like histoplasmosis and sarcoidosis. Liquefactive you will see where? In brain abscess, acute pancreatitis. Coagulative is most common type. So here it is chronic pancreatitis, you will see fat necrosis. Done? Okay, moving to next one. Now, a 45-year-old male patient presented to hematologist with complaint of weakness and fatigue. So there is weakness and fatigue. Lab investigation reveals a decrease in hemoglobin and reticulocyte count. Hemoglobin means RBC, reticulocyte count means baby RBC. Baby RBC, adult RBC, both are less. While WBC platelets are normal. So they are telling you WBCs and platelets, they are normal. Bone marrow is having a selective decrease in erythroid precursor cell. So I can say here, look at the script. Question is telling you reticulocyte count is less and mature RBC, they are less. So it means it's something which is not a hemolytic anemia. Because hemolytic anemia, what will happen? When adult RBCs are dying, they will give a signal to bone marrow, and bone marrow will produce more and more RBCs. So baby form will be more. So in understand this thing, in hemolytic anemia, reticulocyte count will increase. Right? So caution is not telling you anything about MCV. So MCV is not mentioned. It means it is not a megaloblastic anemia. It is not an iron deficiency. In aplastic anemia, what you will see? You will see pancytopenia. In aplastic anemia, you will see RBC, WBC, but here it is written. You can clearly see WBC and platelets are normal. So it means it's not aplastic. So what we call this? We call this pure red cell aplasia. Get my point? It is pure red cell aplasia, and just remember, this occur because of parvovirus B19. It occurred because of parvovirus B19. So parvovirus B19, understand this thing. This can cause pure red cell aplasia. It can cause pure red cell aplasia. Means only RBC will decrease, WBC platelet will be normal. Second is like in those patients who already have sickle cell anemia, it can convert that sickle cell into pancytopenia, means sickle cell into aplastic anemia. So what we call this, it can cause aplastic crisis. We can call this aplastic crisis, where in a patient of sickle cell anemia, it can cause aplastic crisis. So this is about your parvovirus B19. Am I clear? Okay, just remember always, whenever a question they are asking you anemia, so first thing you have to see in anemia question, MCV, that is means corpuscular volume. So first thing you should approach is MCV. MCV normal value will see 80 to 100 femtoliter. And when MCV value, it is less than 80, we call this microcytic. 80 to 100, we call this normocytic. And more than 100, we call this macrocytic. So just remember, this is very, very important. So first thing you have to see MCV. So less than 80 means where you see this in Sheetal. What is Sheetal now? Sheetal S stands for sideroblastic anemia. Sideroblastic anemia. I stand for IDA, iron deficiency anemia. T is your thalassemia. T is your thalassemia. A is AOCD, anemia of 26, and L is your lead poisoning. L will be your lead poisoning. So first thing you have to see MCV value. Now look at this. Suppose if MCV value is normal, then it is mostly your hemolytic anemia. Hemolytic anemia. If it is not hemolytic anemia, then it's a problem of bone marrow. Like it could be like parvovirus B19 infection. So it could be either aplastic anemia, or I can say it could be pure red cell aplasia. Pure red cell aplasia. Or possibilities, it could be like a CKD patient, because CKD patient, they have no erythropoietin. Now coming to more than 100. More than 100 means what we call this, it is either a B12 deficiency or it is B9 deficiency. B12, B9, or it could be due to liver disease, or it could be due to thyroid disease. Right? So understand this thing. This is about your different types of anemia. So what we have to see, first thing we have to see in the question is MCV value. MCV value. Is it clear? Okay, now look at this. अरे तुम बोर हो रहे हो तो चले जाओ तुम, कोई बात नहीं, बाकियों को पढ़ने दो. Let's see the next one. So understand this thing. Anemia question में first thing what you have to see is you have to see MCV value. तो सबसे पहले आपको MCV देखना. अगर क्वेश्चन में understand this thing, if MCV value is given less than 80, तो answer will be any of this. Sheetal means sideroblastic, IDA, thalassemia, IOCD, lead poisoning. Right? Okay, now moving to next one. This question like 10 attempts in a row. बार 10 attempts से आ रहा है. What could be a new thing in here? A 35-year-old woman present with colicky abdominal pain. There is colicky abdominal pain, joint pain, and palpable purpura. Again, whenever you see a question on palpable purpura, so understand this thing. Don't be in a hurry. Don't be in a hurry. Just remember, always see the question carefully. Analysis only RBCs with no other significant finding. Only RBC you can see in urine. Following is a likely diagnosis. So what it is? Now understand. In Behçet syndrome, what you will see? In Behçet syndrome, you will see patient will have recurrent oral ulcers, recurrent genital ulcers, right? Multiple hint will be oral ulcers, genital ulcers, and some eye manifestation. In microscopic polyangiitis, you will see here there will be Sianka. Sorry, here will be Pianka. Now, what is this granulomatous with polyangiitis? This is another name of vaginus. So here you will find Sianka. So this is IgA vasculitis. IgA vasculitis is also called as HSP, Hinox-Stollen purpura. Now, what they are asking now, see, they have asked this question a lot of time. But now what they are asking in HSP, how you will manage. So expected, what is expected is treatment of HSP. Treatment of HSP. Okay, बताओ treatment of HSP. बताओ rebel, Rai, Billy. Anyone? How you will manage HSP? So understand this thing, it's a self-limiting condition. ये क्वेश्चन आने के बहुत ज़्यादा चांसेस हैं. So this you already know. But if it is not self-limiting, then what we have to use? We have to use steroid. We have to use steroid in low dose. We have to use steroid in low dose. That is called 0.25 or 2.5 mg per kg body. Then now try to understand this thing. What is the question which already came in INICET and this is expected question in your exam? Like what is indication? Steroid आप कब दोगे? So what are the indication of steroid in HSP? So देखो, every patient you will not give steroid. What are the indication? So indication of steroid, when you will give steroid to patient. अब इसको देखो, steroid आप कब दोगे? First is clear, when it is not self-limiting. When this is not self-limiting. When it is not self-limiting. Then when we give, right? Yes. When, what you said? When there is renal involvement, not particularly renal involvement, particularly what? When there is GI bleeding. अगर किसी पेशेंट को GI bleeding और I can say any bleeding, कहीं से ब्लीडिंग हो रही है, तब आपको स्टेरॉइड देना है इमीडिएटली इन द फर्स्ट विजिट. व्हाट एल्स? देखो, रीनल इन्वॉल्वमेंट रितेश सबको होगा, बिकॉज मोस्ट पीपल दे विल हैव एसोसिएशन विद IgA nephropathy, right? So mild hematuria is seen, so that in that involvement we will not give. But if it is like a massive condition, what else? Severe abdominal pain, very very important. अगर बच्चा है, रो रहा है, then we have to use steroid. Just remember, when it is not self-limiting, when patient is having GI bleeding or any bleeding, or there is severe abdominal pain, in these scenarios we give steroid, and this is very very high chance to come expected question in this attempt. ये लास्ट ईयर INICET में आया था, इस बार आपके में आ सकता है. वेरी वेरी इंपॉर्टेंट. Okay, so this was the topic of vasculitis. Just remember, vasculitis, what we have to see, you have to see vasculitis, it can be due to antibody mediated or it can be due to antigen antibody complex. Antigen antibody complex. So antibody mediated antigen antibody complex. बताओ रितेश, हीरा, टैंक, शेफाली, कहाँ गया वो? तो चला गया रिबेल. तुम्हें बता दो. Where we find antigen antibody complex? It is also called as immune complex. We also call this immune complex. We call this immune complex. To understand this thing, this immune complex is something which is type 3 hypersensitivity. Type 3 hypersensitivity, and it is seen where? It is seen in PAN. PAN means polyarteritis nodosa. So which vasculitis will have immune complex? PAN. अब देखो एंटीबॉडी कौन सी होती है? तो एंटीबॉडी, when we see antibody, so antibody can be either ANCA or it could be anti-endothelial antibody. Anti-endothelial antibody. So when we say anti-endothelial antibody, understand this thing, it is something that we see in a patient of anyone? Antibodies against endothelium? Kawasaki. Very good. This is seen in Kawasaki disease. And ANCA, when you see this ANCA we can further classify into two categories. So we can have PANCA or we can have CANCA. So आजकल देखो PANCA CANCA नहीं पूछते, are asking you different name. So PANCA is also called as anti-MPO. P anca is also called as anti-myeloperoxidase, and C anca is also called as anti-PR3. P anca, C anca. Now understand this thing. P anca, C anca. So P anca, where we see, it is seen in Churg-Strauss syndrome and microscopic polyangiitis. And C anca is something which we see in Wegener's. C anca is something that we see in Wegener. So this is the classification which you have to remember. Am I clear? So Wegener's की spelling को just I am changing to Wegener's. So Wegener's means it is C4, C anca, C4 Wegener's. So this is about antibody which you have to remember. Done. Okay, now you're asking, this is like essential क्रायोग्लोबिनुरिया कंडीशन होती है, उसको बोलते हैं एसेंशियल मिक्स्ड. शेफाली सुनो ध्यान से. जैसे कंडीशन वस्कुलाइटिस है, रेयर टाइप वस्कुलाइटिस कॉल्ड एसेंशियल मिक्स्ड क्रायोग्लोबिनुरिया. एसेंशियल मिक्स्ड क्रायोग्लोबिनुरिया. It is like medium to small vessel vasculitis. It's a rare condition. Just remember, it is associated with hepatitis C. ये hepatitis C के पेशेंट के साथ होती है. That's what you have to remember. है ना clear? This is essential mixed cryoglobulinemia. So this is about your vasculitis that you have to remember. आगे चले. Okay, बताओ. Following is having hexanucleotide repeat. तो बेसिकली अब आपको पता होना चाहिए ट्राइन्यूक्लियोटाइड रिपीट से ऊपर क्वेश्चन पूछ रहे. So here I am adding one more option. बताओ. So where you will see what type of repeat. Fragile X syndrome, Huntington disease. So Huntington disease will have which repeat? CAG repeat. Myotonia dystrophy will have CTG repeat. There's one more called Friedreich's ataxia. And Friedreich's ataxia will have GAA repeat. Fragile X syndrome is left now. Here you will find CGG repeat. CAG, CTG, GA. So these are four conditions. Understand? ये चारों में क्या होगा? In these four conditions you will find trinucleotide repeat. What we call them? We call them TNR. TNR का मतलब क्या होगा? Trinucleotide repeat. Done? So CGG, CAG, CTG, GA. Now frontotemporal dementia in short what we call this FTD. FTD. And there is one more condition called ALS. Anyone remember what is ALS? Amyotrophic lateral sclerosis. इसको हम बोलते हैं लू गेरिक्स डिसीज और स्टीफन हॉकिंग्स डिसीज. So ALS and FTD, these are two conditions. Here you will find hexanucleotide repeat. Here you will find hexanucleotide repeat. So this is about your hexanucleotide. So these four are trinucleotide repeat. Done? Am I clear? Yes, this is trinucleotide repeat. Now just remember, all those diseases which will have trinucleotide repeat, they will have a property. And what is the name of that property? So they will have a property. That property will be, as generation advances, disease occur early and with more symptoms. उसको देखो, let's suppose this is your grandfather, this is father, and this is you. So grandfather, father, you. Suppose grandfather is having the same disease at the age of 40. Father had the same disease in his 30, and you had the same disease in your 20. So now look at the face which I am making here. Try to understand this thing. When you see grandfather, he is smiling, he is chill. Father is a bit sad, and you are crying. You are crying. So now try to understand this thing. As generation advances, disease occur early and with more symptoms. जैसे जैसे बीमारी बढ़ती है. Yes, SOD1 mutation. Yes, Shivani, it is superoxide dismutase gene mutation. ALS, what we give? What in treatment we give? Riluzole and edaravone. Drug जो देते हैं, that is riluzole and edaravone. Now look at this, you can see as generation progresses, disease occur early and with more symptom. तो जैसे जैसे पीढ़ी बढ़ती है सिम्टम जल्दी होते हैं और सिम्टम ज़्यादा होते हैं और जल्दी होते हैं. तो दिस इज व्हाट वी कॉल, इसको बोलते हैं एंटिसिपेशन. दिस कंडीशन इज कॉल्ड एज एंटिसिपेशन और शर्मैन्स पैराडॉक्स. Anticipation, or I can say Sherman's paradox. Anticipation or Sherman's paradox. So this is about your hexanucleotide repeat. Done? Clear? Am I clear, guys? आगे चलो. Okay, now try to answer next one. Dermatitis herpetiformis. अब ये क्वेश्चन मुझे पता है, all of you are knowing this thing, but the question here is to tell you about a disease called celiac. देखो यहाँ से क्वेश्चन आता है. So this you are knowing. Dermatitis herpetiformis. It's a type of vesico-bullous disease. This is seen in a patient with celiac disease. Not in Crohn disease, not in Whipple disease, not in ulcerative colitis. So here I'll talk about celiac. Okay, now see, Whipple disease also is a favorite topic nowadays. They're asking many questions. Just remember, two things they ask you on Whipples. First is cause. Cause क्या होगा? Cause will be Trophy Whipple. Trophy Whipple. And next remember, here you will find pars positive macrophage. Now coming to celiac disease, they ask you a lot of questions. So let's start with all the MCQs. They ask you bro, barley, rye, oat, wheat. So this bro should be avoided. So patients having hypersensitivity to barley, rye, oat, wheat. So just remember, R is rye. R is not rice. Rice can be given. The last attempt में ये भी आया था, rice pulao can be given. So rice should be avoided. Rice can be given. Now in celiac proof, what they ask you name of HLA. Anyone बताओ कौन सा HLA होता. Then they ask you name of antibody. Then they ask you association. Association. And what else they ask you? They ask you, this is expected question, ये कभी आया नहीं है because all other question came in exam. What type of lymphoma patient will develop in this? Okay, बताओ फटाफट. Come on. What is the name of HLA in celiac proof? What is the name of HLA in celiac proof? Which HLA? HLA will be DQ2, DQ8. Antibodies. Antibodies. Which antibody? Come on. Anti-TTG, which is most sensitive antibody. And anti-endomycin. Which is most specific antibody. Sensitive antibody, specific antibody. Association. एक तो अभी मैंने बताया था, that is dermatitis herpetiformis. Then what else? It can be associated with type 1 diabetes. Then it can be seen in a patient of anyone. It can be seen in a patient of Sjogren syndrome. It can be seen in a patient of Hashimoto's thyroiditis. This DH is dermatitis herpetiformis. So these are association. Then even also remember, it is also associated with Down syndrome. Now this is very, very interesting. This is expected question. Which lymphoma? So normally in GIT, what we get? We get B cell non-Hodgkin lymphoma. Here you will get T cell lymphoma. And this T cell lymphoma is also called as enteropathy associated lymphoma, EAL. Enteropathy associated lymphoma. Enteropathy associated lymphoma. So this is expected in celiac. And you all know like how we make a diagnosis. In biopsy, what you will find? So in histopath, you will find villus atrophy and crypt hyperplasia. Villus atrophy plus crypt hyperplasia. So this will be the investigation of choice. Means biopsy will be the investigation of choice. And this is the pathognomonic feature. Very, very important. Okay, now look at the next one. A 50-year-old woman with history of fever and weight loss presented with cervical lymphadenopathy. So any in the question in the patient, whenever you see a patient of cervical lymphadenopathy, first thing should come into your brain will be TB. Simple. सबसे पहले क्या आना चाहिए? TB. Biopsy is having granulomatous necrotizing inflammation, orbit blights. It's more confirming towards TB. So it is actually a patient of tuberculosis. So they ask you what you will find in TB, which type of calcification. So we can have two type of calcification: dystrophic calcification and metastatic calcification. Dystrophic and metastatic calcification. So understand this thing. Dystrophic calcification, D for dystrophic, D for dead. D for dead means I can say dead tissue or necrotic tissue. So it is seen in those tissue which are already dead. Metastatic is seen in live tissue. It is seen in those tissue which is alive. So necrotic tissue, live tissue. So dead people can't move. Understand? Dead people can't move. So serum calcium will not move. So what about serum calcium? So serum calcium in this case, it will be normal. In metastatic M for more calcium. So there will be more serum calcium. Serum calcium will be more. That. So now they ask you where you will find dystrophic calcification, where you will find metastatic calcification. So understand this thing. Dystrophic calcification you will find where? In Rath most PG medicine. So Rath is most important to get PG in medicine. So what is this Rath? Understand this thing. Rath is rheumatic fever. In rheumatic fever, because of dystrophic calcification, these bodies are called Ashoff bodies. A is atherosclerosis. Atherosclerosis. T is TB of lymph node. And lymph node की TB को क्या बोलते हैं? What we call this? We call this scrofula or scrofuloderma. Now M is meningioma. Meningioma. With M we have mesothelioma. Mesothelioma. O is ovary, salivary gland, and thyroid. Ovary, salivary gland, thyroid means tumor. We have papillary cancer of ovary, salivary gland, thyroid. So basically, they are papillary cancer. Basically, which cancer? Papillary cancer. So they can ask you papillary carcinoma of ovary, salivary gland, thyroid. P is prolactinoma. Prolactinoma. G is glucagonoma. And M stands for Monckeberg sclerosis. Monckeberg sclerosis. Done. So these are Rath most PG medicine. Now understand this thing. Metastatic where you will find where? You will find in those conditions which are leading or ending into CKD, like multiple myeloma, like I can say hyperparathyroidism. Hyperparathyroidism, multiple myeloma, sarcoidosis. Then we have milk alkali syndrome. Milk alkali syndrome. Then we have vitamin D toxicity. Vitamin D intoxication, vitamin D toxicity. This most is most important because in most what we have some of bodies. So in most here what you will get some of bodies. Some of bodies. So let's see now question. So they are asking you TB. So one thing is clear, in TB you will not have metastatic calcification, you will have dystrophic calcification. So these two options are ruled out. देखो मेटास्टैटिक में सीरम कैल्शियम नॉर्मल तो होता ही नहीं, rolled out. In metastatic serum calcium is increased, but it is not seen in TB. So diagnosis clear, it is TB. TB of lymph node. So you will see in dystrophic calcification, serum calcium is dystrophic में calcium increase नहीं होता सर. So either they ask you question on calcification means calcium value, or they ask you example. Simple. Okay, now moving to next. The following blood group can be given to a patient with Bombay blood. So Bombay वाले को क्या दे सकते हैं? So Bombay blood group patient should always receive blood from Bombay phenotype. Answer should be Bombay phenotype, but that is not given the option. So we will give a drug. We will give a blood that is free from any type of antigen. So we prefer to give O negative. Simple. We will not give AB negative, B negative. We will prefer universal donor, that's your O negative. Am I clear? Okay, let's understand this different type of blood group. So we have most common blood group. Then we have least blood group, least common. Then they ask you like a best blood group to transfuse. Okay, most common blood group. Anyone? Most common blood group, it is your O positive. Least common, least common is Bombay phenotype. Best to transfuse blood, it is called cross match blood. If cross match is not available, then we prefer O negative, or then we prefer O positive. Cross match means, suppose my blood group is AB positive, you have to give me AB positive. Now just try to understand this thing. Whenever they ask you a question of blood group, what they ask you what are pre-transfusion testing protocol. Pre-transfusion testing means, suppose you are donating blood, then your blood will be screened for 5 infection. This is very, very important. They ask you again and again. It is hepatitis B, hepatitis C, HIV, syphilis, and malaria. So your blood should be screened for 5 infection. Am I clear? So these are 5 infections where your blood should be screened. Hepatitis B, C, syphilis, HIV, malaria. Okay, moving to next. Try to answer. A 7-month-old boy presented with 2-day history of fever and abscess over the neck. Fever and abscess over the neck. Mother revealed that child had similar recurrent infection in the past. DHR test, dihydrorhodamine test, is found to be positive. What is? What is the diagnosis? What do you think? So this is called CGD. Okay, now understand. Chidiac-Higashi syndrome, it occurs basically due to list gene mutation. List gene, and what they ask you, patient will have a giant granules or large granules in cytoplasm. There will be giant granules. Now coming to SCID. SCID means severe combined immunodeficiency. This is, I can say, occur due to adenosine deaminase defect. And yet there will be like a decrease in all cell line. B cell, T cell, NK cell, all will be decreased. TB, you know, like in very detail. So answer is CGD. Now what is CGD? Understand. CGD occur due to deficiency of which enzyme? It occur due to NADPH oxidase deficiency. NADPH oxidase deficiency. So whenever this enzyme is deficient, so this NADPH oxidase is also called respiratory burst enzyme. So respiratory burst enzyme, to understand this thing, bacteria cannot be killed, so there will be recurrent infection. Increased risk of infection with catalase positive bacteria. Catalase positive bacteria like Pseudomonas, Staphylococcus aureus. Catalase positive bacteria. Now understand these CGD. Whenever you see a patient of CGD, remember how we make a diagnosis. They have different tests. So 2 tests what they ask in exam. Which test? Anyone? Which test? Anyone? एक तो अभी लिखा हुआ DHR test. So sometime in exam they ask you DHR test and sometime they ask you this test. Anyone? देखो पिछली बार DHR पूछा था, इस बार ये वाला पूछते हैं. Which test they ask? NBT test. Nitrogen blue tetrazolium chloride test. So this is expected question. CGD, how we make a diagnosis? By NBT, nitrogen blue tetrazolium, or we can use DHR test, dihydrorhodamine test. Okay, now let's next look at the next one. अभी मैंने आपको बताया था अनीमिया का अप्रोच, राइट? अनीमिया अप्रोच. तो बताओ व्हाट विल बी द आंसर. एक लौंडा था जिसको बोर लग रहा था, कहाँ गया वो? गायब हो गया. बताओ. नाउ ट्राई टू आंसर. शिफाली रितेश, बताओ. यू आर आंसरिंग गुड, आई एम नोटिसिंग यू. बताओ बताओ. ऑल गुड. व्हाट इट इज? सबसे पहले क्या देखना है? व्हाट आई टोल्ड यू, एमसीवी. सो लुक एट दिस. लो एमसीवी रिटर्न. अभी मैंने बताया था, जस्ट रिमेंबर नाउ इट दे आर आस्किंग क्लिनिकल क्वेश्चन. सो लो एमसीवी मींस एमसीवी वैल्यू. देखो यहाँ पे नॉर्मल भी दे दिया हुआ है. सो एमसीवी लो दिया हुआ, तो इस आंसर किस में से होगा? आंसर विल बी इन शीटा. गेट माय पॉइंट? समझ आई मेरी बात? तो शीतल में से क्या बचा? मेगालोब्लास्टिक रूल आउट हो गया. Now look at this. 30-year-old woman presented with pallor and fatigue. Hemoglobin is 5, MCH 24, leukocytes 11,000, platelet 5 lakhs. Low ferritin. Ferritin is low. Anemia of chronic disease में क्या होता है? Ferritin high होता है because store form is more. Now look at this. MC normal value देती है. Then they are telling you about total iron binding capacity. In sideroblastic anemia also ferritin is more. So low ferritin and high TIBC. It's the classical feature of iron deficiency. So what I will do now, I want you to understand three different types of anemia. First is IDA. Second is AOCD. AOCD. And third will be sideroblastic anemia. And this type of question they ask you again and again. How we differentiate these three? Look at the screen. Try to understand. So what are the three parameters which they ask in exam? तीन पैरामीटर कौन से होते? First is they ask you about serum iron. Second is serum ferritin. And third is TIBC. टोटल आयन बाइंडिंग कैपेसिटी. अब इसको देखो एक बार इस लेक्चर के बाद जस्ट यू हैव टू मेक दिस वंस अगेन विथ योर ओन हैंड. इट्स वेरी वेरी सिंपल. जस्ट रिमेंबर, always remember ferritin. Whenever we see ferritin, this ferritin is always inversely proportional to TIBC. So whenever you see ferritin, this ferritin is inversely proportional to TIBC. So अगर ferritin बढ़ेगा TIBC कम होगा. So in iron deficiency anemia, understand, in iron deficiency first सबसे पहले क्या कम होगा? फर्स्ट टू डिक्रीज विल बी सीरम फेरेटिन. सबसे पहले स्टोर कम होता है. फेरेटिन स्टोर फॉर्म. सो इन आयरन डेफिशिएंसी यू विल सी फर्स्ट थिंग दैट डिक्रीज इट विल बी स्टोर फॉर्म. सो स्टोर फॉर्म मींस फेरेटिन. उसके बाद क्या कम होगा? देन सीरम आयरन विल डिक्रीज. एंड व्हाट आई टोल्ड यू, फेरेटिन इज इनवर्सली प्रोपोर्शनल टू टीआईबीसी, सो टीआईबीसी विल इंक्रीज. तो आयरन डेफिशिएंसी इज क्लियर. In anemia of chronic disease, means chronic inflammation will produce macrophage. Macrophage with the help of a protein called hepcidin, they will trap all the iron within store. So it's like lockdown. It's like COVID lockdown. So lockdown, people are more at the home. So here iron is more in the stores, but not in the blood. So store form is, this is store form. So ferritin will reflect the store. So store form is more, but in the serum it is less. Right? And what about this TIBC? TIBC will be decreased. Right? रटना नहीं, इसको समझो. ऐसे एग्जाम में रटोगे टॉपिक तो दिक्कत होगी. दैट विल बी मोर कॉम्प्लिकेटेड. इट्स वेरी सिंपल. AOCD is like chronic inflammation, store. Now sideroblastic anemia, it is iron toxicity. More iron in the store, more iron in the blood. Simple. What about TIBC? So TIBC will be simple. This you have to remember. Done. So this is a summary about different types of anemia, how we approach, especially microcytic anemia. बाकी तो सिंपल होते हैं. देखो microcytic B12 B9 तो ही पूछते हैं. सिंपल है ना? क्लियर? Okay, now moving to next. Try to answer. A 10-year-old boy present with complaint of hematuria. Hematuria, first hint, hypertension and facial puffiness for 3 days. History reveals he had sore throat infection 2 weeks back. Urine examination shows positive for albumin, means urine में albumin का loss हो रहा है. Following is most likely diagnosis. Try to answer. So understand this thing. It's a question on glomerulonephritis. So we categorize this into two categories. Means we divide this into nephritic syndrome and nephrotic syndrome. So nephritic. So now try to understand this thing. In nephritic syndrome, what you will see? In nephritic syndrome, the classical feature will be hematuria. The patient will develop hematuria. In nephrotic syndrome, the classical feature will be lipiduria. Then remember, here you will find proteinuria, and that proteinuria is having a range. This range is called as more than 3.5 gram per day. More than 3.5 gram per day proteinuria. Here proteinuria will be less than this, means proteinuria will be minimal. Proteinuria will be there, but that is always less than 3.5 gram per day. Get my point? So they ask you a medicine question. What is nephrotic range proteinuria? 3.5. Now understand this thing. In nephritic, what you will see, the disease which are purely nephritic, this you can remember by mnemonic PARI. PARI means ये पापा की परी नहीं है, this is PARI. PARI stand for PSG. PSG. With A we have LPOT, and we have anti-GBM. Anti-GBM is anti-glomerular basement membrane. R is RPGN, and I is IgA nephropathy. IgA nephropathy. Sorry. Now understand this thing. Nephrotic. What we have in nephrotic? We have MCD, minimal change disease. We have MGN, MCD, and what we have? We have FSG. So these are purely which are nephrotic. Then remember there are two conditions which will have feature of both nephritic as well as nephrotic. What are these two conditions? So one is your MPGN, second is your DPGN. DPGN is also called as lupus nephritis. So अब देखो क्वेश्चन में हिंट क्या लिखा हुआ है? They are telling you about hematuria means it's more likely a nephritic syndrome. Done. So hematuria means it is nephritic syndrome. So nephritic syndrome you can see PSGN, post streptococcus. It is caused by group A beta hemolytic streptococcus. This group A beta hemolytic streptococcus will cause two conditions. One is PSGN, and this will also cause rheumatic fever. Simple. It can cause rheumatic fever. Done. Okay, moving to next. So simple है. A girl with intellectual disability present to OPD with following finding. You can see the image. Endocardial cushion defect. So what is the diagnosis? Okay, so genetic syndrome से आपसे एग्जाम में पूछते हैं what is the cushion defect where you will see this where in Down syndrome. Just remember they ask you cardiac manifestation of different genetic syndrome. So first is I can say Down syndrome. So they ask you name of syndrome and they ask you cardiovascular system defect. So starting with the first one, we have Down syndrome. Then they ask you Turner syndrome, Klinefelter syndrome, Marfan syndrome, Noonan syndrome, DiGeorge syndrome. Okay, so understand Down syndrome. Cardiac defect you will see that is called endocardial cushion defect. Endocardial cushion defect. But in exam, what they ask you? They ask you VSD and ESD. Right? VSD, ESD. Okay. Now coming to Turner syndrome. Turner syndrome, what they ask? Turner syndrome, most common cardiac defect. Anyone? Can you tell me most common? It will be bicuspid aortic valve. Bicuspid aortic valve. It is most common, but in exam, what they ask? They ask you coarctation of aorta. Klinefelter syndrome. There will be mitral valve prolapse, and this mitral valve prolapse is most common cause of MR. Later on, you can convert into MR. In Marfan syndrome, you can get the same thing. Mitral valve prolapse, which can convert later into MR. Just remember, Marfan syndrome patient can also develop aortic dissection. Aortic dissection, and this aortic dissection is the cause of death. Noonan syndrome, ये भी क्वेश्चन आया हुआ है. You will get PS. PS means pulmonary stenosis. DiGeorge syndrome, this question also came in exam. You will get pathology of phylum. So देखो ये all these questions at some point of time came in exam. So just I am writing here all MCQs. All these are MCQs which came in exam. Genetic syndrome. Now see, Pratik, in Patau and Edward, you can develop VSD and ESD. Patau, Edward can also develop VSD, ESD. Here you can see they can develop VSD, ESD. Am I okay? Okay, age associated with syndrome. Age, now see, most of these are genetic syndromes, so there is no particular age. They can occur in any age, but most of them occur less than 10 years. जो आप वेर यू आर वांट टू आस्क मी समथिंग नर्सन दिस थिंग, वो क्वेश्चन डाउन का आता है, पर ठीक अंडरस्टैंड दिस थिंग. इन डाउन व्हाट दे आस्क यू, इन डाउन syndrome remember cardiovascular system defect, they will develop in less than 5 years. जब बच्चा 5 साल के आसपास होगा, उससे छोटा होगा. इन डाउन syndrome what they ask you, AML occur in less than 3 years. In Down syndrome, ALL will occur when a child is reaching to his 20s, means in the age of 10 to 20. जब बच्चा 10 से 20 साल का होगा तब उसको क्या होगा, ALL होगा. 3 साल के पहले AML होगा. 5 साल के पहले क्या होगा, कार्डियोवास्कुलर डिफेक्ट. और अगर ये सपोज ही सर्वाइव्ड लॉन्ग मीन्स in the age of 30 to 40 he can also develop Alzheimer disease. Alzheimer he will develop in when he's in the age of 30 to 40 years. तो Alzheimer भी इनको जल्दी होता है. Done? Okay, let's see. Which cells are responsible for graft rejection? Simple the question आता, try to answer. So most abundant cells are T cells. So T cells are responsible for graft rejection. Is it clear? Yes, Pratik, it's AML M7. Yes, very good. It is M7 AML that occur in Down syndrome. It is M7 type. This is AML M7 type. Right? Okay, now look at this. A family pedigree chart is given. Find the condition. First, try to answer this. Look at the pedigree. So in pedigree, understand this thing. We have certain rules. So rule number 1. So rule number 1 is we have to rule out mitochondrial and mosaicism. We have to rule out mitochondrial and mosaicism. तो आपको रूल आउट करना. रूल नंबर 2, अंडरस्टैंड दिस थिंग. We have to see dominant or recessive. We have to see dominant or recessive. इसके तो सबसे पहले आपको रूल आउट करना क्या है, माइटोकॉन्ड्रिया. तो माइटोकॉन्ड्रिया मींस इफ मदर इज अफेक्टेड, ऑल बेबीज विल बी अफेक्टेड. फ्रॉम फादर, नो वन. मोजाइकिज्म, सब कुछ नॉर्मल होगा, ऑल फैमिली विल बी नॉर्मल, सडनली देयर विल बी अ डिफेक्ट. एक बच्चे को डिसीज होगी, दैट्स इट. सो अनदर दिस थिंग, इन डोमिनेंट रिसेसिव व्हाट वी हैव टू सी स्किपिंग. We have to see skipping. So skipping absent means dominant, skip present means recessive. Absent means dominant. So when we see recessive is of two types. If you see only boys are affected, then this is your XLR. XLR means X-linked recessive. If I can say both boys and girls, if you see both sex affected, then this is autosomal recessive. Right? Now coming to dominant, understand in dominant what we have to see male to male transmission. In dominant what we are seeing male to male transmission. So when we see male to male transmission, means from male to male, father to son. If male to male transmission is present, then more chance of autosomal dominant. If it's suppose absent, or we cannot identify male to male transmission, question mark, it's like suppose a father is having only female child. In that case, what we see, are all daughters of affected dad also affected? So when you see, answer will be a yes or a no. When you see no, when you see no, then it is your when you see yes, then it is your X-linked dominant. And when you see a no, then again answer will become autosomal dominant. Getting my point? So just remember this flow chart. Is it clear? Okay, now look at this. Try to understand this. अब पहले इसको देखो. Mitochondrial तो नहीं है. So you can see skipping is absent. Skipping is absent means all generation are affected. In medicine, I will not take, Ashish sir will take. Look at this. If you see skipping is absent, absent means what we call recessive is ruled out. So it rule out. Okay. Now look at this male to male transmission. Can you see? This is male to male transmission. Male to male transmission is there. And can you see, are all daughters of affected dad? Look at this, affected dad once again. It's affected dad. Daughter number one, daughter number two. Are all daughters affected? No. All daughters are not affected. It means it is autosomal dominant. This time of pedigree, they ask an exam. Simple. It is autosomal dominant. Okay, moving to next one. Following stain is used for detection of hemocysteine. Mason Fontana किसके लिए होता है पहले ये बताओ. Mason Fontana. Where we use Mason Fontana? Anyone? Mason Fontana. Melanin. Okay, oil red O and Sudan black. These both are for lipid. Just remember, lips, first word, lip, L-I-P, lip. So girls use lipstick, so they have red lips. Boys have black lips, simple. Lipids or fat, we have oil red O. For hemosiderin, for iron, or sometimes they can ask you like for sideroblastic anemia. For sideroblastic anemia, what we use? We use pearl stain or Prussian blue. We use pearl stain or Prussian blue. Done? Okay, आगे देखो. Now, this is the approach. मैंने आपको एक approach बताया था anemia का. Now I am telling you the approach of leukemia. So first try to understand, try to answer this. A 38-year-old man presents with bleeding gums for 20 days. Now see, whenever you see bleeding gums, then something gets your brain, that is AML or myeloid leukemia. For 20 days, he have gingival hyperplasia, gum hyperplasia. Hepatosplenomegaly, lymphadenopathy. So by seeing so many symptoms, look at this. When you see so many symptoms, if you see many first of all, when you see many symptoms and a lot of I can say plasma cells, a lot of blast cells. When you see a lot of blast, we can say 100 or 30 with many blast cells. So when you see a lot of symptoms, more than 20% blast cells in bone marrow, that means that is suggestive of acute leukemia. Acute leukemia means it could be AML or ALL. Here they are telling you all the options of AML. Now look at the skin and try to understand the thing. When you see all these, and remember these myeloid cells, they are positive for myeloperoxidase. Okay, here is written that peroxidase negative and non-specific esterase positive. So again, that's also feature of myeloid cells. So clear-cut hint in the question is which leukemia will have gum hyperplasia. It's a classical feature that we see in M4 and M5. M2 is called chloroma. It is most common type. M2 is most common type diagnosed. M0 will not have any symptom. M7 is something which just now I think somebody said M7 is associated with Down syndrome. It is associated with Down syndrome. So gum hyperplasia is seen in M4 and M5 and more classically in M5. Then, now what I am telling you the approach of leukemia. So first try to understand this thing. In leukemia, what you have to see सबसे पहले क्वेश्चन को क्या ढूंढना है आपके अंदर. You have to see blast cells. Look at the blast cells percentage. Or even suppose in sometime in the question they will not give you blast cells percentage. Just focus on this thing. एक लाइन ली होगी MPA, myeloid peroxidase. Sudan black. These stains are given, or they will have used this stain. Myeloid peroxidase, Sudan black, or they have used oil red O. So try to understand this thing. Suppose when you see myeloid peroxidase given in the MCQ, or they have given TDT in the MCQ, TDT and pass, MPO Sudan black. मेरी बात ध्यान से समझो. अगर क्वेश्चन में दिया हुआ है ऐसे हिंट, because sometimes they ask you this type of question, then remember this cells will be myeloid in origin and this cells will be lymphoid in origin. मेरे कहने का क्या मतलब ना सी, In lymphoid origin, we have two leukemias. We have ALL, CLL. ALL, CLL. In myeloid origin, we have two leukemia, AML, CML. Get my point? तो क्वेश्चन में सबसे पहले what you have to do, what you have to see is MPO दिया sodium black दिया. Now see the question blast cell percentage or symptom. If blast cell percentage are more than 20, suppose question is given like this, more than 20% blast cells or lot of symptoms, cells are positive for MPO sodium black, it is AML. In CML it will be less than 20. Same acute leukemia में क्या होगा, more than 20. Chronic में क्या होगा, less than 20. Get my point? तो मेरी बात ध्यान से समझो. फर्स्ट ऑफ ऑल सी टीडीटी पास एमपीओ सोडन ब्लैक क्या दिया हुआ. एमपीओ सोडन ब्लैक दिया, इट मींस इट्स अ माइल्ड ल्यूकेमिया. ब्लास्ट सेल्स 20% से ज्यादा दिए गए, एएमएल 20 से कम दिए गए, सीएमएल. टीडीटी पास पॉजिटिव, ब्लास्ट सेल्स मोर देन 20%, एएमएल. Okay, they ask you most common leukemia in Down syndrome. Yes, it's ALL. Most common leukemia in Down syndrome in children under 3 years of first 3 years of birth, it will be AML and 7. Clear, Pratik? So this approach you need to keep in mind. Done? Okay, now try to answer. A 70-year-old man present with chronic low back pain. पीठ में दर्द हो रहा है. Fatigue and headache for the last few weeks. Pallor and bony tenderness. ESR. Now see, ESR in the question is the biggest hit. Suppose if you see in any MCQ, ESR value more than 60. ESR value more than 60, just remember rule of 60. 60-year-old female, ESR more than 60, then think of temporal arteritis. Temporal arteritis. And when you see ESR value more than 100, it's something that's a feature of multiple myeloma. Get my point? When you see ESR value more than 100, ESR is increase in sepsis, in fever, in high grade fever. Suppose patient को बुखार नहीं है, sepsis नहीं है, ESR बढ़ा हुआ है, it could be temporal or multiple myeloma. Simple. Skull is having multiple punched out lesions, so diagnosis clear. So diagnosis clear, it is multiple myeloma. So they are asking you what is the best test. The best test should be biopsy. Biopsy option. Now what will do? Biopsy is not even the option. So CT head. Look at this. They are telling you skull radiograph is having punched out lesion. Means skull X-ray is having lighted lesion. CT, you can see this lesion more prominent. जब X-ray में आपको देखना CT की जरूरत है, नहीं जरूरत है. CT is not needed. Now look at this. Whole body scan. Whole body scan you will do. When? Whole body scan हम करेंगे. I'm not telling we will not do. We will do this. But it is done for staging. It is done for staging of disease. कि multiple myeloma कितना फैला हुआ है, staging, or I can say for prognosis we do this. Is it clear? But not for diagnosis. For diagnosis what we do? CA level 15 का बताया था मैंने आपको. Breast cancer, that's not done here. So what we do? We do SPEP. It's called SPEP, serum protein electrophoresis. In SPEP what we'll find? We'll find M spike. And M spike is seen in which area? It is seen in IgG area. M spike you will find where? In IgG area. Right? So this is about your multiple myeloma. So what they ask you multiple myeloma, look at the screen. They ask you few MCQs like all the MCQs of multiple myeloma I'm writing here. They ask you Russell bodies. Russell bodies. Dutcher bodies. Then what are the cells you will find? You will find cells like flame cells, Mott cells, flame cells, Mott cells. In RBC you will see one above another. What do we call this? We call this Roulet formation. Roulet formation. Then remember in multiple myeloma, calcium is increased, ESR is increased. But what is normal? Alkaline phosphatase is normal. Alkaline phosphatase value will be normal. ये increase नहीं होता. Is it clear? In multiple myeloma, you will see amyloid. Which amyloid? AL type of amyloid. AL amyloid also called as primary amyloid. Then what they ask you how we make a diagnosis. For this we have to do SPEP. In SPEP you will find M spike. And this M spike you will find in IgG area, or sometimes you will find this M spike where? In IgA area. Then remember in the urine you can find Bence-Jones protein. Bence-Jones protein. So these are all the MCQs of multiple myeloma. Okay, now try to answer this. अब इसको बताओ. One more genetics. Color blindness. I have told you to read the genetic table. मैंने एक main class में आपको genetic table बताई थी. That table is very very important. एनी गेसेस? तुक्का मारो चलो. एंड आई टोल्ड यू, सपोज अगर आंसर नहीं आ रहा तो क्या आंसर मार्क करना है, दैट इज द आंसर. एनीबॉडी रिमेंबर? शिफाली, ये सर बढ़ता है, कम नहीं होता. ये सर इंक्रीजेस नॉट डिक्रीजेस. ESR decrease कहाँ होता है? ESR is absent or not increase. It will never increase. Where? In a condition called A fibrinogenemia. बताओ. कलर ब्लाइंडनेस. बताओ बताओ. आई शो द जेनेटिक टेबल. मैंने एक टेबल आपको बताई थी एंड आई टोल्ड यू सारी जेनेटिक्स एक तरफ and that table is on another side. So I'm attaching this table in this PDF. This PDF will be shared in your NLC group. तो उस टेबल को एक बार एग्जाम से पहले देख के जरूर जाना है. दैट टेबल इज एक्सट्रीमली एक्सट्रीमली इंपॉर्टेंट. मैंने बताया था, कुछ याद आ रहा है? एनीबॉडी रिमेंबर? I told you like entire genetics on one side and we have a genetic table on another side. And I am warning you again कि वो टेबल से हर बार क्वेश्चन आता है, इस बार भी आएगा. In every attempt you will get a question from the table. तो देखो, एक बार इसको एक काम करो, अगर याद नहीं हो रहा तो उसको एक बार लिख लो without any mnemonic, because in exam sometimes what happens, you remember the mnemonic but you forget the content of mnemonic. So look at this. This was the table which we have discussed, right? Get my point? कहाँ दिख रहा है कलर ब्लाइंडनेस? आपको कहीं दिख रहा है कलर ब्लाइंडनेस? कैन यू सी हियर? कैन यू सी कलर ब्लाइंडनेस? पॉइंट नंबर 8. Excellent, right? So this table is very very important. So what I am doing, I am just adding this table in this PDF. And this PDF will be shared to you. Right? The answer will be excellent. Okay, now let us see some one-liners which came in exam. Which is the enzyme that prevent the shortening of telomeres? Quickly, fast, बताओ. Which enzyme prevent? It is telomerase. Telomerase. Okay, they ask you, and this telomerase, remember, it is the enzyme that prevents shortening of telomeres. Clinical scenario of midline swelling, weight loss, and presence of empty appearing nuclei. Cause orphan eye nuclei. Which cancer? They are seen in which cancer? Come on. अभी बताया था मैंने. Orphan eye nuclei. You will see in which cancer? It is seen in papillary cancer of thyroid. It is seen where? In papillary carcinoma of thyroid. Right? Okay, now look at this. Try to answer. Dash is one of the most common cause of nephrotic syndrome in patients suffering from cancer. Interesting question. Little twist. Most common cause of nephrotic syndrome overall is MCD, minimal changes. But यहाँ पर आपसे मुनि पूछ रहे हैं. अभी मैंने आपको बताया था क्या क्या था नेफ्रोटिक में. व्हाट वी हैव? MCD, we have MGN, and we have FSGS. That so overall most common and most common children, it will be MCD. But the one which is suffering from cancer or some systemic disease, then answer will be MGN. Getting my point? Yes, very good, Ritesh. Now samoma bodies मैंने अभी बताई थी आपको. Where you see samoma bodies? It is seen in most. क्या था most? papillary cancer. कहाँ का papillary cancer? Papillary cancer of ovary. So we sometimes also call it serous cyst adenoma. Salivary gland and thyroid. And M4, meningioma, mesothelioma. So these are the things where you will find samoma bodies. That P2S2 M2 जैसे तुमको याद करना ऐसे याद रख लो. Like our mnemonic is most. Meningioma is usually papillary cancer of ovary, cervical, and thyroid. Simple. Okay, which type of cancer is associated with arsenic, thorotrust, and vinyl chloride? Sometimes they will not give you vinyl chloride, they will give you PVC. PVC means polyvinyl chloride. और they can tell you pipe industry. कहाँ पे यूज होता है? It is used in pipe industry. So कौन सा कैंसर होता है? बताओ anyone. Which cancer you will see in pipe industry? Come on. It is angiosarcoma. It is angiosarcoma of liver. Done? Okay. Now look at this. So this is TTC test. So I am adding all the image based question here. Look at the screen. TTC test. So this you can see, this is pale yellow color. This is ischemia area. Ischemia area. And this brick red, you can see this is viable tissue. This is viable tissue. What we call this triphenyl tetrazolium chloride test. Right? TTC test. So this image also came in exam sometimes. Sometimes they ask you image, sometimes they ask you theory this question. Okay, now see Mott cells. This is Mott cells. So you can see this is the Mott cell. This is, you can see mottling is there. And along with this, you can notice here RBCs are clumping above one another. इसको क्या बोलते हैं? It's called Rayleigh formation. This also question came in exam. So Rayleigh formation. So both these things where we see, these are seen in a patient of multiple myeloma. Done? Yes. Pale will be ischemia and brick red will be viable tissue. Okay, now try to understand this. This is what we can see: starry sky, we can see tingible body macrophage. These are basically your tingible body macrophage. The macrophage along with tumor cells, we call them tingible body macrophage, and what we call the starry sky appearance. So this image is repeat MCQ कई बार आ चुका है. Starry sky appearance. In Burkitt, just remember one more thing, they ask you name of gene. It is CMYC gene. And name of translocation, what they ask you? Translocation 840. 840. Done? Yes. Jaw swelling, African child. Identical twin से कौन सा graft होता है? Come on. What we call this? Syngeneic graft or isograft. Okay, now suppose they give you like target cells, or they can use sometime what teardrop cells, anisosporocytosis, Mender index less than 13. What it is? So Mender index value less than 13, it is seen in thalassemia. And just remember, this Mender index value is more than 13, it is seen in IDA, iron deficiency anemia. Mender index, very, very important. All these are previously repeat topics, very, very important. Okay, now look at this. You can see this is your teardrop cells. Teardrop cells. And here you can see like absence of all the cells. We call this acellularity. So teardrop cells with acellularity, it is a feature of myelofibrosis. Myelofibrosis. So teardrop cells, just remember, it can also be seen in thalassemia. Okay, let's now see. Anaphylaxis following consumption of prawns. किसी ने prawns खाए. That is IgE mediated reaction, or what do we call this? We call this which type of hypersensitivity? It is type 1. It is type 1 hypersensitivity. Tau proteins means they are hyperphosphorylated, and where they are seen in a patient of Alzheimer's disease. They are seen in a patient of Alzheimer's disease. Tau protein. Done? Alzheimer's disease. आगे चलो. Okay, dash is seen as yellow brown pigment which can be seen in liver and heart of normal aging patient. And what that pigment will do? This pigment will slowly shrink your organs. We call this brown atrophy. So they ask you brown atrophy of heart, brown atrophy of lung, brown atrophy of liver. Let us see where with which pigment? Lipofuscin. So lipofuscin is the pigment. Yes, Alzheimer you will get heranobodies. Very good. Okay, this is retinoblastoma. What is the name of rosette? क्या बोलते हैं rosette को? What rosette we call this? It is flexner interstitial rosette. Flexner interstitial rosette. So just remember it is due to RB gene mutation. Okay, they also ask you, suppose if any person who is having familial form of retinoblastoma, so they are at risk of developing two more tumor, osteosarcoma. अगर किसी पेशेंट को retinoblastoma है, so they can develop osteosarcoma and they can develop pinealoblastoma. So there is risk of, if any patient who is having familial form, they can develop retinoblastoma, they can also develop osteosarcoma and pinealoblastoma. This question also can, most common second tumor seen in a patient of retinoblastoma, it is osteosarcoma. Okay, now look at this normal cell, and what we have these Sternberg cells, so it will have a typical owl's eye appearance. Owl's eye appearance. Now don't forget owl's eye inclusion body is CMV. Where will we see? CMV. So owl's eye cells, it is these Sternberg cells. Owl's eye inclusion bodies. Owl's eye inclusion bodies. It is seen in CMV. Right? Okay, now what it is? This is called Rokitansky protuberance. Even this image came in exam, so that's why I've added this image. Rokitansky protuberance. Okay, this is ring sideroblast. You can see here, this is ring sideroblast. And for this ring sideroblast, what we need? We need pearl stain, same stain, Prussian blue. You need Prussian blue stain. This is pseudo Pelger Hewitt anomaly. These are pawn ball megakaryocytes. So these are some image based question. Yes, this is Rokitansky protuberance. You can see where in teratoma. Okay, earliest cells to appear because of chemotaxis. बताओ chemotaxis की वजह से सबसे पहले कौन से cells आएंगे? Which cells will appear first? In chemotaxis we study about neutrophils. So first cells will be neutrophils. Get my point? So first cells will be neutrophils. Clinical features such as type 1 hypersensitivity reaction. These are mediated by which cells? अगर देखो question है, they are mediated by which antibody? So answer is IgE. But if they ask you they are mediated by which cells, then answer will be eosinophils. Simple. Okay. Assist with all three germ layer. What do we call this? Is most likely to be also called as dermoid cyst. So what is another name of dermoid cyst? This is teratoma. This is teratoma, right? Okay, which gene mutation will cause hemochromatosis? So hemochromatosis occur because of which gene? HFE gene mutation. It occurs because of HFE gene mutation, right? HFE gene. Okay, now let's look at few more image based questions. You can see this is coagulative necrosis. So just we will quickly go. You can see here this is like a wedge shape, typical wedge shape infarct. Look at this now. This is your liquefactive necrosis. Everything is labeled, so you can just read this PDF later on. Liquefactive necrosis. And this is your cottage cheese like material, so we call this caseous necrosis. And this is this yellow you can see. This yellow will be fat globules. And this white material will be necrotic. This is your necrosis. Yellow will be your fat. This will be fat. Get my point? So necrosis in between, you will see yellow fat globules because it's fat necrosis. This is fibrin pink like meshwork. We call this fibrinoid necrosis. Just remember it is in those conditions where we have type 3, or I can say immune complex, type 3 hypersensitivity. Yes. Okay, reversible we have discussed already. Look at this now. Pycnosis shrinking, karyorexis. So pycnosis shrinking. Then we have karyorexis, fragmentation, karyolysis, disappearance. So these are nuclear changes where? In irreversible cell injury. Right? Okay, this also we have discussed. Okay, now look at this. What it is? Step ladder pattern. The step ladder pattern where we see in apoptosis, and that is because of which enzyme? That is because of endonuclease. It occurs because of which enzyme? Endonuclease. Right? Okay, this is wet gangrene image. You can see this wet gangrene. Then you can see this is dry gangrene. This one will be your dry gangrene. And both the gangrene you can see where? You can see in diabetes patient. This is metaplasia. Just remember metaplasia, most common cause. Most common cause will be smoker's lung. Most common cause will be smoker's lung. Now this is your lipofuscin. It is like, we also call this pigment of aging. Pigment of aging. Or we call this wear and tear pigment. It will cause brown atrophy that we have discussed. Now coming to Werner syndrome. So what is Werner syndrome? Understand this thing. It is nothing. It is premature aging. Premature aging. We call this Werner syndrome. Then remember how we differentiate keloid from hypertrophic scar. You can see this keloid. Keloid is something that go beyond the boundaries. It will have irregular borders. And this keloid, how we manage? We manage by giving an injection directly here. Which injection we give? We call this intralesional triamcinolone. Intralesional triamcinolone. Done. Okay, this is hypertrophic scar, so it will not go beyond the boundaries. We call this hypertrophic scar. This is like different. So you can see this is scar, this hypertrophic scar, and this will be keloid. Okay, then red versus white infarct. Where we see red infarct? So red infarct where we see? In white infarct where we see? Just remember, white you see in heart, spleen, kidney. In heart, spleen, and kidney, you will find white infarct. In lung, liver, brain, you will find red infarct. Done. So they ask you like all are defect of right, where you'll see red infarct except, right? Okay. Yes, keloid can go beyond boundary. Okay, now stains we are discussed. This is again you can see Prussian blue. So Prussian blue we use in multiple purpose. So sometimes they ask you, this is like a blue color stain. We use for hemosiderin, for iron. This is your sarcoma bodies which we have discussed in detail. Just remember most: meningioma, mesothelioma, ovary, salivary gland type. Okay, now acute inflammation steps you have to remember like margination, rolling. So just remember what they ask you in exam. They ask you question on rolling. So rolling is done because of selectors. Then they ask you adhesion. Adhesion is done because of integrants. And CAM, cell adhesion molecule. And then what they ask you transmigration. It is because of transmigration, PCAM. What is the CD marker for PCAM? It is CD31. Then they ask you chemotaxis. Chemotaxis, what they ask you? LIC. It is leukotrienes B4, interleukin 8, and complement C5. Right? Last, what they ask you? Opsonization. Opsonization. Understand? It occurs because of C3b, C-reactive protein, fibrinogen, and they ask you which antibody causes. It is IgG. Very, very important. It's very, very important about acute inflammation step. Right? Okay, now moving to chronic inflammation. What they ask you, what are the markers for chronic inflammation? Just remember, in chronic inflammation, we have two markers. First is called VEGF. VEGF will cause angiogenesis. Angiogenesis means new vessel formation. That is why chronic inflammation will increase the risk of cancer. It will increase the risk of cancer. So chronic inflammation में cancer क्यों होता है? Because of VEGF. Second is we have TGF beta. TGF beta will cause fibrosis. So that's why, like for example, I can say initially there is hepatitis, right? Hepatitis can convert into cirrhosis. In cirrhosis you will have fibrosis. There is a doubt. Before rolling, we do margination. Yes, these steps you have to remember. The steps are also simple. Just remember the steps. The steps you can remember by mnemonic: Mr. Ram, or you can say Raju or Rahim. Mr. Ram alone took care of people. So Mr. means margination. So first step is margination. So margination is nothing important, that's why I skipped that. R is rolling. Alone is addition. Then what we have? We have transmigration, also called as diapedesis. This is chemotaxis. O is opsonization. And P is phagocytosis. Simple. So margination, rolling, addition. Done. So this is about your steps, all the steps. Okay, आगे चलते हैं. Now these mediators also we have discussed. Now let's talk about giant cells. So you can just label this giant cells. So this type of giant cell is called Reed-Sternberg giant cells. And these are seen where? In a patient of Hodgkin lymphoma. It is called as Taunton giant cells. And this is seen in a patient of xanthoma. This is your map-like or amoeba-like giant cells. What we call this? We call this Warthin-Finkelday giant cells. And this Warthin-Finkelday is seen in measles. This is your Langerhans giant cells. And this Langerhans giant cells you will see where? In TB. So these are all 4 types of giant cells which you will see. Done? Done? Okay, now these are your granuloma. So you can see donut shaped granuloma. This is something which we see like it look like a donut. Where we see donut, it is seen in QC. And this is like a granuloma. You can see in the brain meninges. So we call this dark granuloma. Dark granuloma. Then you can see this is your stellate shaped granuloma. This is your star shape, or I can say stellate shape. Stellate granuloma, where you'll see where? In cat scratch disease. Toxoplasmosis. So these are different types of granuloma which they ask us in an image-based question. Okay, now dysplasia and aplasia, the main difference you can see, the main difference between these they ask in exam. In anaplasia, you will find high mitotic index, so we call them mitotic figures. And you can see in anaplasia, what we see, we can see sometimes giant cells. And because of those all these, and henceforth it is considered most dangerous. It is considered most dangerous. So out of these to remember, anaplasia, dysplasia, most dangerous will be anaplasia. How we differentiate? High mitotic index, mitotic figure, giant cells, and it's most dangerous. Now loss of polarity you will see in both. Okay, then we have proto-oncogene, tumor suppressor gene, which they ask in exam. Next one topic they ask you on microbial carcinogen. So these are those topics which you have, if you can read from your notes, then you are prepared. Then you are revising. So proto-oncogene is important, tumor suppressor gene is important. Then paraneoplastic, very very important. This is a list of tumor marker which I am adding here. You can study on your own. Then this genetic tables again added. So that's very very important. Then this is mitochondrial items. You can see from mother all babies, from father no one, from mother all, father no one, mother all, father no one. So mitochondrial means from mom it will affect all, from dad it will affect none. Then what else they ask you? They ask you Down syndrome. So again you can see like a prominent epicanthic fold, trisomy chromosome 21. Then you can see difference between Klinefelter And just one more something new which they have added, like in this is your Turner syndrome. In Turner, just remember the risk of heart disease. It's like a new update given in Harrison also, even in pediatric textbooks given. Like people will have this type of neck, right? This type of neck. This type of neck is called what we call Dashui Mundi, webbed neck. So what is a new update? Understand this thing. More the webbing. This webbing is directly proportional to cardiovascular system disease. जिस पेशेंट की जितनी मुंडी धसी हुई होगी उतने कार्डियोवास्कुलर डिजीज के चांस बढ़ेंगे. वेरी वेरी इंपॉर्टेंट. इट्स अ न्यू अपडेट. Clear? And just remember, time filter, they ask you a new MCQ. The increased risk of SL. This increased risk of SL in time filter. Then this is, you can see Turner syndrome. Karyotype will be XO. XO. Then Marfan syndrome, you can see all the features. Again, that's an important topic. This we have repeat. We have discussed already. Tried repeat, like Huntington, myotonic dystrophy. Genomic imprinting, we have Prader-Willi and Angelman. Prader-Willi and Angelman syndrome. Then this is again, you can see Turner syndrome. Then they ask you question on hypersensitivity. So this table is also written here. Right? Hypersensitivity table, especially they ask you question on either type 1 or type 4, type 5. This they ask you frequently in exam. Then graft autoantibodies, amyloidosis, immunodeficiency, these are important topics. Then you can see some named morphology in anemia, like where we'll see target cell, where you'll see, I can say bite cells, where you will see Rowley formation, Howell Jolly body. So these are all the MCQs which they ask in exam. Okay, now look at this. Somehow another hematology images is hypersegmented neutrophils, where we see in B12 and B9 deficiency. This is spirocytes, means spherical cells. This is ellipsoidal, means ellipsoidal. So understand this thing. This is seen there in hereditary elliptocytosis, and it is seen in hereditary spirocytosis. But most common cause will be AIHA, autoimmune hemolytic anemia. Done. Rowley formation, I told you where. Rowley formation in multiple myeloma. This is stomatocytosis, means RBCs will have a cleft in between. It is sometime later, sometime it can be due to those people, those who daily drink alcohol, means daily alcohol intake. Target cells, so T4 target, T4 target, T4 thalassemia. T4 target, T4 thalassemia. Done. Okay, now look at this. This is Papa-Niemann bodies. You can see Papa-Niemann bodies there in a patient with sideroblastic anemia. Sideroblastic anemia, you can find Papa-Niemann bodies. And this is your chipmunk face. Where we see chipmunk face, you can see in thalassemia patient. Sometimes you can also see in sickle cell anemia, but mainly thalassemia patient. Again, you can see spirocytes. Where we see spirocytes, hereditary spirocytosis and AIHA. This is birth cells. Birth cells we will see in uremia. Uremia means in CKD patient or in a patient of AKI. In CKD patient or sometimes a patient of acute kidney injury. We call this echinocytes or birth cells. This is spur cells we will see in A beta lipoproteinemia. Howell Jolly body, you can see this blue color body. This is like a blue color body. It is nucleus remnant. So nucleus remnant means nucleus will be stained blue. And this nucleus remnant, understand this thing. It is seen in those patients who don't have spleen, means asplenia. Or I can say post splenectomy. Then teardrop cells, you can see T4 teardrop, T4 target, T4 thalassemia. So it can be seen in thalassemia patient. And you can also see this there in myelofibrosis. Myelofibrosis. Okay, then stippled RBCs, you can see stippling. It is seen where in sideroblastic anemia. Sometimes they will not give the word sideroblastic, they will use the term lead poison. Lead poison is actually a type of sideroblastic anemia. Stippled RBCs. Right? Okay, now see, you can see this is a slide of myelofibrosis, which sometimes it look like a plastic anemia slide. Okay, then this is Heinz bodies. Heinz bodies, understand, they are red in color. For this, what we need supravital stain. So they are stained by supravital stain. These are red color bodies. Previously, I told you that was Howell Jolly body, that was blue in color. This is red color bodies. This Heinz body, it is seen where in a patient with G6PD deficiency. G6PD deficiency. Then you can notice this is your bite cells. Bite cells are also seen in G6PD deficiency. This is your Pelger-Hewitt anomaly. You can see spectacle-like nucleus. We call this Pelger-Hewitt anomaly. You can see this like in a patient of sometimes myelodysplastic syndrome. You can see this even in some chronic inflammation. Dole bodies, again, Dole bodies, you can see it's a marker of inflammation. But sometimes Dole bodies can also be seen in myelodysplastic syndrome. This is giant granules. You can see this giant granules where we see in Chediak-Higashi syndrome. Chediak-Higashi syndrome. This reticulocyte, you can see this is the blue color stain. This blue color stain for reticulocyte. What do we call this? Brilliant crystal blue. Brilliant crystal blue, also called as new methylene blue. New methylene blue. Done. Okay, then we have AML. So in AML, you can see these different types of cells in AML. What we call them? We call them Fagor cells. Fagor cells. This is oil rods. So oil rods, you can see again, oil rods are feature of AML. But maximum you will find where? In M3ML. Maximum oil rod you will find where? In M3ML. Then we have CML. For CML, now they ask you question on like a pharmacological management. So we have imatinib, first generation drug. Then we have DNB. This is second generation drug. We have third generation drug, and we have a new drug. So new drug means this is the new generation, or I can say a fourth generation drug. That calls omacetaxib. So these are different type of. So DNB means D and B. These are second generation tyrosine kinase inhibitor. And okay, then this is just remember the name of staging system. This is called Rye and Binet staging system. So Rye and Binet staging system. It is staging system for CLL. Just remember the name. Okay, non-Hodgkin lymphoma we have discussed. Now look at this. This is very, very important. Which virus can cause which condition? This question came many times in exam. Even I am expecting this is one MCQ. Mark my word. One short question. This thing we have written twice in the routine class. In neoplasia as well as in hematology. Like which virus will cause which type of malignancy. एग्जाम के बाद मैं बताऊंगा दोबारा से यहाँ से क्वेश्चन पक्का है. Very, very important. Okay, then this is just remember the name again. Rye and Binet was for CLL. Hodgkin lymphoma के लिए कौन सी होती है? Ann Arbor staging. Just remember the staging names. Ann Arbor staging. Okay, now see Burkitt's and diffuse large B-cell lymphoma. Just remember both are dangerous tumor. But out of these two, if you have to choose one, most dangerous will be DLBC. Most dangerous will be DLBC. Then this is your adult T-cell leukemia. So you can see a flower-shaped nucleus. You can clearly see a flower-shaped nucleus that is seen there in adult T-cell leukemia. That is due to HTLV1. किससे होता है? It is caused by HTLV1 virus. Done. Okay, then this classification we have discussed. Multiple myeloma we have discussed. These are sometimes they ask you like these Mott cells, Russell bodies, Dutcher bodies, flame cells. These are finding of multiple myeloma. So all these finding you will find there in a patient of multiple myeloma. This is flame cells. You can see this Mott cell image already came in exam. It already aa chuka. This is Russell bodies and Dutcher bodies. This is Rowley formation. So all these are findings seen in multiple myeloma. This is your lytic lesion, or we call them punched out lesion. So these are punched out lesion. Punched out lesion or lytic lesion in patient of multiple myeloma. Okay, then this is brain tumor again. यहाँ पर भी थोड़ा सा डिटेल लिख दिया. I will discuss it in detail already. The brain tumor. Then you can see this temporal arteritis. What they ask you? Temporal arteritis image. Rule of 60. Female above 60. ASR more than 60. So generally it is seen in female above 60. Then this is expected question. They ask you like which condition. Polymyalgia rheumatic, understand this is something which is associated with temporal arteritis. It is something that is associated with temporal arteritis. Takayasu's, just remember how we make a diagnosis. It is involving your deeper vessels. So here you will do CTNG. CTNG. Now look at this. Takayasu always patient younger, means less than 50. Temporal always old above 60. This is pathology test. Pathology test किसके लिए करते हैं? We do pathology test for Behcet syndrome. For Behcet syndrome, what we do pathology test. Okay, this is your fibrinoid necrosis. So where we see fibrinoid necrosis in PAN, in polyarteritis, you will find fibrinoid necrosis. Kawasaki by Kawasaki disease. Just remember anti-endothelial antibodies and management. What we give aspirin and IVIG. Okay, the last is what they ask you. They ask you like patient will develop conjunctivitis, and this conjunctivitis is non-purulent. So there will be non-purulent conjunctivitis. What is expected? Like we have a new drug which we can use, that is your anakinra. So what is anakinra? It is interleukin-1 antagonist. Interleukin-1 antagonist. This is your Berger disease, or we call this thromboangiitis obliterans. Seen in young smokers. This is your Churg-Strauss syndrome. You can see rash of Churg-Strauss syndrome. You can see rash, mononeuritis. This is your examiner favorite HSP, Hinox-Schollen purpura. This you can see a deformity in the nose. We call this saddle nose. Saddle nose, and saddle nose is classical feature we see in Wegeners. Sorry, Wegeners. I will change the spelling. Wegeners. Why Wegeners? C for CMK. C for drug of choice, cyclophosphamide. So C for antibody name, CMK. Drug of choice in this condition will be cyclophosphamide. Cyclophosphamide. That. Okay, now lung cancer, again an important topic. You have to study in detail. Very, very important. What else they ask you in lungs? What else they ask you in lungs? Remember, they ask you sometime question on like 3C. 3C means Crayola bodies, Charcot living crystals, Kirschmann spiral. These are seen in asthma, right? Yes, saddle nose you can see in many conditions. Saddle nose you can see in leprosy also. Then what they ask you question asbestos. So in asbestos, what they ask you, which type of body? Sphaerogenous body. Sphaerogenous bodies. Okay, now they ask you question on FAP and colon cancer, familial adenomatous polyposis. So FAP, colon cancer, FAP is APC gene, chromosome 5. APC gene, chromosome 5. And colon cancer, just remember, it is something like a FAP can convert into colon cancer. So in colon cancer, they ask you which drug is protective. So they ask you aspirin prevent colon cancer. So these are those list of topics which you have to study from your main notes when you revise the content. Okay. So this is like what we have discussed. We have wrapped up entire pathology in this 2.5 hour. A very, very important session. So first we have discussed all the PYQs. So whether you know it or you don't know it, like in this 2 hour, we have discussed from 2020 to 2025. All the questions we have covered. मैंने सारे क्वेश्चन डिस्कस कर लिए. So there is no need to solve question from any other source. Just watch this video. एक बार 1.5x पे देख लो, सारे क्वेश्चन इसमें कवर है जो पिछले पैथोलॉजी के क्वेश्चन. So what this nothing like only 8-9 days are left. Just don't be in any negative surroundings. Just remember you can do it. All the best. ज़्यादा सोचना नहीं है, सब अच्छा होगा. Just manifest. Believe in manifestation. You did this before. You are going to do it again. Right, with this I'll conclude. All the best, and remember, you can, you will. Bye-bye. CEA is tumor marker pratik. It's not a gene. Right? CEA is a tumor, carcinoembryonic antigen. Right? Thank you so much, guys. Any other doubt you can ask me.